Hello, friends. Hope you had a great weekend. I also enjoyed this weekend. We had 2 days holiday, second Saturday being holiday here. This afternoon, I had to chair a session in Western UP ISOPAB, and the topic was almost similar, preterm labor. Cervical insufficiency is one of the causes of that. I hope you have uh, realized that this is a very, very important topic and very, very important topic, both from the practical point of view as well as exam point of view. And I have updated this talk with the article published in 2022 also. So let's not waste time because there's a lot of things to be covered. I hope I will be able to cover this. Doesn't matter if I can't cover, then it will go to part 2 anyway tomorrow. Cervical insufficiency, diagnosis and management is the name I have given. Obviously, the cause also will be dealt as I speak. First of all, we need to understand that cervical insufficiency is not all or none phenomenon, but a continuous variable. It keeps on changing. Even as you do the ultrasound, you can see the dynamic changes of the cervix sometimes. Often my colleagues have told me that. So cervical insufficiency is actually a spectrum of initial cervical dilatation, going on to shortening of the cervix, then funneling, and finally ending with second trimester abortion or a preterm labor. What's the definition of cervical insufficiency? There's a lot of confusion, even among consultants, that the contraction that leads to shortening of cervix, is it cervical insufficiency? Let us see. It's a recurrent, every word is important. That's why I'm disclosing one by one. It has to be recurrent. This is a very important word in the definition. Painless, this all of us know. Cervical dilatation leading to second trimester pregnancy losses. So that is cervical insufficiency. ACOG has slightly twisted the definition, but essentially the meaning is same. Inability of cervix to retain a pregnancy in second trimester, which obviously means second trimester loss. In the absence of, they are more explicit, in the absence of clinical contractions, instead of saying painless, they are more explicit by saying no contractions leading to cervical effacement or shortening, or labor, or both. This has to be clearly understood before we deal with the case of cervical insufficiency. So it is recurrent, painless, and in the absence of contractions, labor, or both. Although it may occur in a single pregnancy, the diagnosis is confirmed when it recurs. Again, I have highlighted the word recurs in consecutive pregnancies. Then only it is cervical insufficiency. In one pregnancy, if you have had a second trimester abortion, it may or may not be due to cervical insufficiency. In case she has a full-term pregnancy in the subsequent pregnancy, that may not be a case of cervical insufficiency. To call it cervical insufficiency, it has to recur in a consecutive pregnancy leading to second trimester loss. What is the pathogenesis? The structural cervical weakness, that is very, very important, is the likely cause. What is the structure then? Cervix is made up of cellular content 10 to 15%, which includes smooth muscle, epithelia, fibroblast. Note here, smooth muscles come under this 10 to 15% only. So not much of contraction and other things going on here. Whereas extracellular, 85 to 90%, consists of collagen type 1, 3, 4, elastin, glycosaminoglycans, and proteoglycans. So where is the question of the smooth muscle relaxation leading on to cervical insufficiency. It is in the absence of contractions due to structural weakness in the cervix. It's inherent. The weakness may be secondary to prior cervical or uterine surgery, for example, dilatation and curettage, or hysteroscopy, where you dilate the cervix, especially if you're using resectoscope. Rarely, it can be a congenital abnormality. That's exactly why, even in the first pregnancy itself, there can be a second trimester loss. Those who have got congenital cervical insufficiency. It can also be associated with decidual inflammation / infection. Yesterday in my talk on the pathogenesis of fibroid, I was talking about every single disease is explained through the theory of inflammation. So here is one more problem that is explained by inflammation. Bleeding at the interface of the decidua and placenta. That can lead to cervical insufficiency, maybe through an inflammatory process. Uterine overdistension. Now, this obviously is due to either a twin pregnancy or multiple pregnancy or polyhydramnios, big baby, that will exert pressure on the cervix. And already weakened cervix, structurally weak cervix, cannot withhold. It's not contractions again, it's a sheer mechanical pressure. That is the one which is giving rise to insufficiency. These other disorders can initiate biochemical changes in the cervix, mainly the inflammation, that lead to premature cervical shortening and often a single, that is non-recurrent, second trimester birth or loss. So what is the cause of a single non-recurrent second trimester loss? These are the causes. Inflammation. But if inflammation remains, then at the lower level, then it can lead to a recurrent loss as well. The classic history, of course, this everybody knows, recurrent second trimester pregnancy losses or live births, often before 24 weeks, no or minimal mild symptoms, cervical effacement and dilatation on physical examination, inconsistent with the degree of uterine activity. There may be some uterine activity whenever there is inflammation, whenever there is choriodecidual hemorrhage, there will be some activity, but the activity is so mild as to give rise to cervical dilatation and effacement. No or minimal contractions. Duration from recognition of symptoms / physical findings to delivery may have been extremely short. So she just says, I had contractions around 9 o'clock, by 10:30, she expels. She doesn't really go through any sort of contractions, pain, and things like that. That is typical history of cervical insufficiency. What are the risk factors? Again, trauma. You have seen a couple of slides earlier that cervical dilatation or any injuries to the cervix, most common cause, may result from processes of labor or birth. Spontaneous labor also can have, after the delivery, if you see the cervix, it looks like cervix is torn everywhere. So that's another thing I used to ask always my PGs. How do you define a cervical tear? Because the cervix looks torn after the delivery. Cervical tear is one which is either actively bleeding of any length, or even if it is not bleeding, if it is more than 2 centimeters, it's called cervical tear. So after spontaneous labor, also there is some amount of injury or trauma to the cervix. And if you use instruments, of course, you don't have to say that. Forceps, vacuum, even cesarean section, because sometimes you may try to dilate the cervix from above in order to later in the postoperative period, you want to the debris to drain properly or locate to drain properly. Congenital cervical abnormalities, as I said earlier, rarely associated with structural cervical weakness and include genetic disorders affecting collagen. They will have other collagen diseases like Ehlers-Danlos syndrome, Uterine anomalies, it may be the cervical incompetency or insufficiency may be a part of general anomalies in the uterus, structural anomalies, or in utero diethyl sylvestrol exposure and biologic variation. Nowadays, nobody uses this DES, so that's the old thinking. History of short cervical length. So suppose somebody had short cervical length in the previous pregnancy, even though they didn't have second trimester abortion, maybe they had just a preterm labor, that history is also a risk factor. However, with regards to short cervical length, what I want to tell you is that short second trimester cervical length alone is not a strong risk factor for cervical insufficiency, as many patients with short cervical length deliver at term, even without intervention. So that is the difficulty in science as such, because 2 + 2 is never 4. That is the beauty also. That is a challenge also for us. Every case is different. So every situation is different. And we have to be carefully evaluating each situation and each case. What are the symptoms? Of course, again, typically between 14 to 20 weeks or weeks before diagnosis, there will be pelvic pressure, Braxton Hicks contractions, premenstrual like cramping and or backache. Usually whenever there's backache, there that means she's getting into labor. That's how it starts, from back it comes to the front. That's what we say. Then change. What is the change? In volume, in color, in consistency of vaginal discharge. These are like the forerunners of cervical insufficiency. There will be plenty of discharge, very thin and colorless maybe sometimes. And in good number of patients, there may not be any symptoms at all. Suddenly, she will have within no time expulsion. So that is cervical insufficiency. Physical examination. In the early time, cervix is soft, closed with minimal effacement. If you happen to see very early in the progression of the things. TOCO, if you apply, no or infrequent contractions at irregular intervals, something like Braxton Hicks contractions, no activity. Provocative maneuvers like suprapubic or fundal pressure, just, this should not be given actually to test the cervical insufficiency, because that can be, the first pressure itself can be dangerous. But if you happen to do it, or Valsalva maneuver, the patient does try to. So the fetal membranes in the endocervical canal or in the vagina can be seen. Maybe what you can do is, as you just do an ultrasound, is just pressure to see whether the cervix is yielding. That's the meaning of it. You should not really do the pressure to see whether the membranes are bulging through the cervical canal, only at the ultrasound, not otherwise. In some, membranes may be prolapsed without provocation or may be ruptured also. So that is also to be kept. When you put a speculum itself, you can see the membranes bulging. That's actually a very late case of cervical insufficiency. Ultrasound, of course, transvaginal sonography is better, absolutely no doubt, because when you do a transabdominal ultrasound, you need at least partially filled bladder that can compress the cervix, and cervical length may look apparently longer, even if it is shortened. So transvaginal sonography is better. You have to look for debris, that is sludge. Fetal squames may be there, vernix, leukocytes, bacteria, or biofilm may be seen in the amniotic fluid, suggesting some sort of inflammation. Cervical length is an independent variable in the prediction of cervical insufficiency and preterm labor, and inversely related to their occurrence. So cervical length is a very, very important factor. Progressive shortening is more predictive than an absolute value. That's exactly why we say serial ultrasound should be done. I'm going to explain that in detail, how frequently, when to start, and what is the normal shortening of the cervix, what is the abnormal shortening of the cervix, everything I'm going to tell. Something like, when we say, what is the weight gain during pregnancy? Undergraduates will say 11 to 12 kgs. I answer, provided she goes through the 9 months. That is the retrospective diagnosis. What as a PG, what as clinicians we know is the dynamic weight gain. That is half a kg per week in the second trimester and third trimester. That is more important for us. We can't wait for the 9 months to say whether she would have gained 11 or 12 kg. So something like that. You can't say let the cervix become 1.5 centimeters, then I will diagnose cervical insufficiency. No, that's wrong. It's too late. It's like after luteing, you have closed the doors of the fold. Cervical length may decrease over time. That also you should see. Very, very rarely dynamic cervical decrease in length will happen as you are doing the ultrasound, but most of the time it is a very slow process. So that's where I'm going to, out of these 5 things, 4 things, that is dilatation, shortening, funneling, and second abortion or preterm labor, I will now concentrate on shortening of the cervix. So as I said, cervix shortens by 0.03 centimeters per week in general population. Of course, we are not going to look at this every day and things like that, but they have calculated over a period of time. It simply means that the cervical shortening is very, very negligible, very, very slow. We can't really look at this 0.03 centimeter and all that unless you are so particular and keen and you have got a very high resolution ultrasound and you are so accurate. It's not possible. It's a calculation. But if the decrease of more than 0.4 centimeters, that means 4 millimeters per week happens, it indicates cervical insufficiency. So that is the meaning of you have to do serial ultrasound to find out. Cervical length is typically short, that is equal to or less than 25 millimeters in cervical insufficiency. Of course, once it reaches that level, there onwards, of course, you are alerted that it's a case of cervical insufficiency now. Shorter than 25 millimeters is optimal cutoff for identifying patients truly at high risk and probably to decide who requires the treatment with whichever modality I'm going to talk. Measuring cervical length as per ACOG guidelines, ultrasonography lacks enough discriminatory power to recommend routine use. So just because you are dealing with a case of probably cervical insufficiency because of her past history, you cannot say, I want to do ultrasound right from the beginning or every week and things like that. Assessment should not begin before 16 to 20 weeks of gestation. One may argue, sir, we have to put a cerclage earlier than that. And now you are suggesting, or I'm not suggesting, but I'm quoting ACOG that you start from 16 to 20 weeks. The logic is the upper portion of cervix is not easily distinguished from the lower segment in early pregnancy. If there has been, I will talk about this history-based, ultrasound-based, and emergency-based cerclages little later, or diagnosis little later. But let us understand that before 16 weeks, even in a high-risk patient, there's no point in measuring for the cervical length. As long as it is okay in the early part of pregnancy, we need not worry. So how to measure the cervical length is a very important, and this is also by ACOG guideline. They have clearly shown, as you can see here, I'm going to highlight them again. You have to take a sagittal plane, and there are 3 landmarks. What are the 3 landmarks? A small, almost V-shaped notch at the internal os. I have made it a red triangle here, and a triangular area of echo density at the external os here, somewhere here, and then a faint line of echolucency between both the canals. So you have to measure only this line. So some people start measuring from here to here and all that cervix. So don't measure the external cervix. You measure this portion. This is the place where you are supposed to measure. So if you measure here from here, you feel that cervix is long. If you measure from here to here, you feel that cervix is short. I hope you are seeing my white arrow as I'm showing, which are wrong places to measure. This is the right place to measure. I'm going to blow up this picture as you can see clearly now, it is from the external os to the internal os. This length is very important for us. And you can make out that by a triangular area here and a triangular area there. And that is the area. So the next thing is, after knowing the length of the cervix, this famous TYVU sign, all of you know that. That is, the acronym goes after this easy remembering sentence, that is, trust your vaginal ultrasound. So first you will see a T sign. That means it's a perfect, competent cervix. There's no problem there. The length is full, as you can see, and the membranes are flat over that cervical internal os. Whereas Y sign means membranes are now making an entry into the upper portion of the cervix. So you can see a Y shape there. And then comes the V shape. The membranes are almost going towards the external os here. You can see that V shaping of the membranes. And when it becomes U shape, that means a big bag of membrane is also bulging. And this patient is going to pose a very big challenge to us. I will show you later in class how to tackle these kind of cases also. So this is what is the dynamism of the cervix. What about lab values? In preterm labor, we say you estimate fibronectin, you estimate CRPs, you estimate the WBCs and all those things. But as far as cervical incompetency or insufficiency is concerned, uncomplicated cervical insufficiency is not associated with lab abnormalities. So only when it is complicated with infection or other things will you see some amount of WBCs and other things. And even fibronectin is only when the membranes rupture, then you can see the fibronectin, fetal fibronectin. It's usually a retrospect rather than a predictor. Now we realize that. So how do you diagnose then? A classic past obstetric history, that is recurrent second trimester loss, painless preferably, most of the time live baby, that's a tragedy. A combination of history plus short cervix on TVS in the current pregnancy. So history is obviously previous pregnancy, but short cervix in the current pregnancy on TVS. I'll come to the teaching what I used to receive when I was a UG and even maybe a PG, that textbooks used to mention how to diagnose cervical insufficiency during pregnancy and in between pregnancy. So what do you think in between pregnancy? Maybe in the next slide. Physical examination showing advanced cervical dilatation and or effacement in the absence of labor and after exclusion of relevant other diagnoses. That is infection, bleeding related, and placental abruption and placenta previa. So it is very clear, history plus ultrasound finding will give us the diagnosis. Effacement and dilatation are usually not detected until TVS cervical length is less than 10 millimeters. So you may not be able to detect this unless the cervix becomes very short. The diagnosis is usually limited to singleton gestations. This diagnosis is what we are talking about. Because the pathogenesis of second trimester pregnancy loss or live birth in multiple gestation is usually unrelated to a weakened cervix. It's a competent cervix which gets pressurized by additional intrauterine volume. So you can't blame the cervix in a multiple pregnancy for yielding. So there are the different mechanisms. It's a mechanism. Even in a normal labor, if you realize with the competent cervix also, I always teach this. There are two drivers of the cervical effacement and dilatation. Number one is uterine contraction, obviously. The longitudinal fibers of the uterine muscle fibers, the circular fibers of the cervix, they are being pulled like a bucket handle. They are pulled. That's one. Number two, sheer mechanical pressure exerted, 360-degree pressure exerted by the head. That is exactly why the head should descend properly for a proper effacement and dilatation of the cervix. So what are the two drivers of the cervical effacement and dilatation? Number one is the uterine contractions. Number two is mechanical pressure by the fetal head. Now, if this doesn't happen, if the cervix still effaces and dilates, it will be hanging loose from the fetal head. So that is a sign of CPD, cephalopelvic disproportion. So anyway, I don't want to divulge much there. I will take a class on that some other time. But today you realize that in multiple pregnancy, in polyhydramnios, and in big babies, the cervix failing is not because of cervical insufficiency per se. It may be because of additional factors. That is the meaning of this particular slide. I hope I'm clear about that. Now, ultrasound-based diagnosis, transvaginal ultrasound screening is discontinued after 24 weeks. Why? Because most of the Western countries are ready to deliver the baby after 23, 24 weeks. They consider that's a viability. In India, we are still sticking to 28 weeks. Maybe we are correct also, because if you deliver the baby too early, you may save the baby and all that. But the chance of cerebral palsy is very high if the baby is delivered before 28 weeks. So maybe in India, we are very prudent that we have not reduced the period of viability from 28 weeks yet. But anyway, after 24 weeks, they think that we can straight away deliver the baby. So there is no point in still looking for the cervix and still putting a stitch or whatever. As cerclage is rarely performed after this gestational age. That's what, according to their meta-analysis, they have found out. In patients with history suggestive of cervical insufficiency, placement of cerclage upon identification of a short cervix on ultrasound is effective in reducing preterm birth, results in pregnancy outcomes comparable to history-indicated cerclage, and avoids cerclage in approximately 60% of patients. So this is the reason why the above sentence is made. Can diagnosis be made before pregnancy? Now I'm answering that question. I asked this question a couple of minutes ago. During my undergraduate days and during the postgraduate days, early postgraduate days also, we used to say that in between pregnancies, you can take an X-ray or HSG, and you can put a number 8 Hagar dilator straight away if it goes, or you can put a Foley's catheter, inflate the bulb, and if you can easily remove it, all these things are gone. It's not done anymore. The diagnosis of cervical insufficiency cannot be made. See, I'm highlighting this word, cannot be made or excluded in non-pregnant patients. So forget it. You don't have to remember at all. By any test, the 3 tests which I mentioned, let me repeat here. Evaluation of cervical function with dilators, that is straight away able to pass 8 number Hagar dilator. Don't ever try that. It can cause very bad vasovagal attack and patient can even die also. Or hysteroscopy is not helpful. Ultrasound, magnetic resonance imaging, MRI, or hysterosalpingography may reveal a uterine anomaly, which is a risk factor for cervical insufficiency, but it is not diagnostic. Not diagnostic of cervical insufficiency. So please remember this. So no effort should be made to diagnose cervical insufficiency before pregnancy. It is always during pregnancy. The only thing that you want to ask about before pregnancy is the history of repeated, recurrent, consecutive second trimester loss, which is painless. I think I will start off with this. Obviously, lots of slides to go. I may go on to the part 2 tomorrow. Let us not hurry up. Let us understand each one of them. Everything is important from the exam point of view as well as from practical point of view. Cerclage and use of progesterone. So this progesterone, basically progesterone producing companies are fighting at every level. Use progesterone in infertility, use progesterone for supporting luteal phase, right from there in the threatened abortion, in recurrent abortions, in even anatomical cause, that is cervical insufficiency, also they find a reason for progesterone, even though the definition says clearly it is not because of uterine contraction. It is structural damage of the cervix, yet progesterone is trying to make its way. Preterm labor, yes, progesterone is definitely being prescribed. So let us look at all these controversies. Let me start and see how much I can go. First is history-based cervical insufficiency. There are three main categories. First category is history-based cervical insufficiency. Cerclage at 12 to 14 weeks of gestation is the best answer. Okay, so there is no doubt in that. Whereas, because anatomical, biochemical, and clinical evidence from observational studies and randomized trials consistently support this approach. So as you can see, there are a lot of, right from 87, 88, and 93. This is old, done and dusted. That's why you don't see any recent papers on this. Cerclage is, no doubt, is the answer. And it is earlier done at 12 to 14 weeks. Now, supplementation of progesterone, I put an asterisk there from 16 weeks. What is the meaning of asterisk? Anybody can tell me? What is the progesterone usually given? Injection 17-hydroxyprogesterone caprate weekly or vaginal progesterone daily until 36 plus 6 weeks of gestation. The choice made by the patient after discussion, whether the patient wants to take weekly injections or whether she wants to keep the vaginal tablets every day. So the asterisk means controversial. I will not want to talk anything more than that. Second category is called ultrasound-based cervical insufficiency. First one was history-based. Now it is ultrasound-based. Cerclage in patients with one prior spontaneous preterm birth and this time TVS cervical length less than 25 millimeter before 24 weeks in the current pregnancy is definitely worth it. So cerclage is the answer again for ultrasound-based cervical insufficiency. What about supplemental progesterone? Again, another asterisk comes there from 16 weeks. It's almost the same answer. It's controversial. Now, alternative approach has been suggested for ultrasound-based CI, that is treat with vaginal progesterone alone without cerclage placement. Now, what to say for this? Only evidence that vaginal progesterone alone may be as effective as cerclage is an indirect meta-analysis of RCTs in which the two groups were not similar. You should understand this in several characteristics, and the cerclage group was at higher risk of preterm birth. So it is, it's not a very good meta-analysis to say that you don't have to put a cerclage, just progesterone is good enough. Maybe I don't want to comment anything more than that. Speaker does not, speaker means me, does not advise this approach, that is giving only progesterone without cerclage in a ultrasound confirmed cervical insufficiency, because a meta-analysis of RCTs found that placement of cerclage upon identification of a short cervix is effective in reducing preterm birth compared to no cerclage. So I would rather go by meta-analysis number 1 rather than the meta-analysis what is given in the small prints. Examination based, number 3, examination based. It's also called sometimes, emergency. Cerclage is reasonable option. Here we are not saying in very clear-cut terms that you must do cerclage. The previous two, history-based cerclage is must, ultrasound-based cerclage is a must, whereas examination-based, it's a reasonable option, preferably called physical examination indicated cerclage. It's also called rescue cerclage or emergency cerclage. Because when you diagnose cervical insufficiency by examination, it's too late. That's why it's called rescue or emergency cerclage. Meta-analysis says it improves outcome compared with no cerclage. So that's why, even though it seems very late, one last ditch attempt of cerclage is still useful. That's what this meta-analysis said. Neonatal survival was 71% with cerclage versus 43% with expectant management. The mean age at diagnosis was 21.7 and 22.8 weeks respectively. The mean time to delivery after diagnosis was 57 and 19 days respectively. So that means if you put a cerclage, she may go on for 57 days, which is very good. 2 months is almost 2 months. Whereas if you didn't put a cerclage, she would only go for another 20 days. The mean gestational age at delivery was 30 weeks, very good, compared to 25.2 weeks, respectively. So examination-based cervical cerclage, most avoid cerclage after 24 weeks. Having said cerclage is better, but you look at this sentence also. Even in this situation, there are only 3 situations. One is history-based, ultrasound-based, examination-based. Examination-based is also called the emergency cerclage or a rescue cerclage. But even here, after 24 weeks, since the procedure may cause accidental rupture of membranes leading to early preterm delivery of a viable infant with its attendant high risk of neonatal morbidity, mortality, especially cerebral palsy. So you may have to go case by case, and depending upon the NICU facilities and things like that. Abroad, they may not want to do a cerclage, they may want to deliver, but in India, we are not ready to deliver at 24 weeks, so we may still consider an emergency cerclage at 24 weeks up to 28 weeks. I have seen doctors putting at 28 weeks also. Their justification is that even if I win 2 days, I will get 2 days for steroid prophylaxis. Yes, I agree. And 1 day for the magnesium sulfate prophylaxis or neuroprophylaxis, maybe, but I will not give a blanket statement. Supplemental progesterone, again an asterisk there, means it is controversial. So at all 3 levels, whether it is history-based, ultrasound-based, or examination-based, progesterone supplementation is controversial. There are special situations like patients with singleton pregnancies and no history of preterm birth or who develop a short cervix are treated with vaginal progesterone. These are special situations. Placement of cerclage may be helpful in those with transvaginal ultrasound where cervical length is less than 1 centimeter.